Emeritus Professor and Consultant Rheumatologist in Kolkata, and Dr. Anu Gulati, who is Associate Professor of Pediatrics at Lady Hardinge Medical College, New Delhi. Welcome, ma'am and sir. These two are the chairpersons for this session. I would also like to introduce our speakers. So our first speaker is Dr. Yoshiya Tanaka, who is from Japan, and Dr. Praveen Hisaria, who is from Australia. Both of them will be giving the talks on this cutting-edge conclave today. Welcome, sir.
Discussing about the deficiency of our immune system. Our immune system is very much sophisticated, and there are two types, one is innate immunity and another is adaptive immunity. In the non-vertebrate, there is only innate immunity, but we have also adaptive immunity. But there are many conditions where this system falls and we have some immunodeficiency disease. And there are many immunodeficiency diseases. One of them is monogenic lupus. The most important part of monogenic lupus is that it is due to one gene. There is some monogenic hypertension such as Crohn's disease, monogenic cardiomyopathy such as hypertrophic obstructive cardiomyopathy. The importance of it, if you can diagnose in the utero, you can get rid of the disease. So without wasting any further time, I request our speaker to start about monogenic lupus.
Yeah, thank you. The vast majority of our patients are polymelic and multifactorial. So as everybody knows, SLEs is originally designated by the erythematosus, erythema, such as facial erythema as seen in this slide. However, many patients are complicated with neuropsychiatric, cardiovascular, renal, hematological, many complications or many organ damages. So such clinical and molecular heterogeneities are common, especially in adult SLE. So when we compare the race, especially in Asia Pacific region and others, for example, China, Hong Kong, Japan, Australia, Korea, Singapore, Taiwan, about 80 to 90% have musculoskeletal disease, about 70% have Maillard rash, and about 50% are renal, but renal is much more than white people. White people, the renal manifestation is only 20%. When compared to white people, but the thrombosis is much less in Asian peoples. Again, there are many heterogeneity among race. Okay. Also, everybody knows interferon signature are high in SLE, but interferon signature means more than 100 interferon-related genes, polygene. Okay. So, but this is very important. So, the reason why it is important is, for instance, cellular interferon activity is usually increased up before the onset, corresponding to other alternatives. From this result or any other evidences, many people realize that interferon should be a very important factor or gene in SLE. So actually, some of type 1 interferon bind to receptors. Type 1 interferon include interferon alpha, beta, epsilon, kappa, omega, and so on. So interferon function is originally antiviral response, but by binding to the receptor, JAK1 activation are induced, and homodimer of STAT1 are phosphorylated, and then gas binding site bearing genes are induced, namely B cell differentiation, T cell differentiation, or macrophage activation are increased. So thus, interferon should have a pivotal role during the pathogenesis of SLE. So then, anti-interferon receptor 1 antibody, anifrolumab, was developed. In these TULIP-2 studies, it was successful. So we have published already about 2 years ago in New England Journal of Medicine. Thus, we realized the importance of interferon. But again, interferon is one of the many genes. So please remember, or when we are the doctors or become a doctor about 20 years ago, everybody knows that SLE is a B-cell disease or B-cell T-cell disease. Acquired immunity or adaptive immunity are highly activated. So actually, in 2011, GWAS study clarified the many disease susceptibility genes. Actually, many of them are B-cell related genes, as shown in the right side. However, at the same time, we also realize, or actually surprised, that there are many genes which are associated with dendritic cells and innate immunity. That was different from our consensus at that time. Why? So, but now everybody knows. For instance, mitosis may secrete RNA or DNA, and this DNA RNA bind to tolerant receptor and induce interferon-mediated signaling and produce multiple cytokines. And these cytokines may activate B cell, T cell, or immune cell adaptive immunity. Thus, such a GWAS becomes more important to know the importance of genome in SLE. From these GWAS, we have found many interesting fun things. In adult onset SLE, up to 100 susceptibility loci of shown in polygenic multifactorial SLE. However, in children or child onset SLE, among more than 30 genes causing the monogenic form of SLE and SLE-like phenotypes. So the term monogenic groups has been introduced to denote SLE patients who carry high penetrance either dominantly or recessively inherited pathogenic variant in a single gene. Right? Pediatrician should know better than I. Anyway, so now many genes, more than about 30 genes are cloned. So schematic representation depicting genes and chromatin locations previously identified to be implicated in monogenic groups. So in terms of diagnosis may be done by clinical and genome. So first, diagnose with one of pathogenic variants in over 30 genes predisposing to SLE and SLE-like disease should be clarified in each patient. Okay, this is one. Another one is clinical diagnosis. One is childhood onset of severe disease, usually younger than 5 years old. Usually, monogenic SLE is child onset. if you can see, if happen to find monogenic lupus in adult onset, that should be carried over from childhood SLE. Okay, usually childhood onset, also parental consanguinity, also presence of family history for autoimmune disease in a first degree relative. Thus, clinical and genomic work can lead to diagnosis. So this variant of groups generally present with early onset severe disease, unfortunately, especially affecting the kidneys and central nervous system. Right? Correct?
Yes.
For instance, this is an example of clinical feature of monogenic lupus. This one is Iracon arthropathy in a patient with type 1 interferopathy. Second one is chill-brain lupus in type 1 interferopathy. This one is meningitis shown in a C1 receptor deficient patient. This one, papillomatosis eruption in PKG delta deficiency. So now the gene involved in monogenic lupus will be categorized in at least 4 or 5 main groups based on the relevant pathways, such as complement pathway, type 1 interferon pathway, self-tolerance pathway, RAS pathway, or other pathways. But the vast majority of the single gene defects that lead to monogenic lupus are categorized under the umbrella of type 1 interferonopathy. About 20 genes belong to type 1 interferonopathy. Why type 1 interferon? Again, self-tolerance occurs through allergy, negative selection, and suppression by regulatory T cells of autoreactive lymphocyte and B cell receptor 18. As a result, apoptosis and netosis can be observed in neutrophils or other cells. Nuclear material accumulates in the extra area, which triggers toll-like receptor TLR if efficiently degraded and removed by the complement system and DNase enzyme. So toll-like receptor also induces transcription of type 1 interferon genes through IRF3. Also, intracellular nucleic acid regulating enzyme and nucleic acid sensors such as TREX1 or RNSH1 and so on also induce transcription of type 1 interferon gene through STING IRF3 axis. Thus, also type 1 interferon binds to their receptor, and with activation of JAK-STAT pathway complex is formed, and this complex induces transcription of interferon alpha, beta, or interferon signatures. Thus, interferonopathy may be a major part of monogenic SLE. So Dr. Omarji found many interesting things. He found that he checked gene variant in each child, and also he checked association with gene variant, genome variant, and their clinical features. So he found that, for instance, glomerulonephritis may be associated with RAG2, C1R, C1S, C4A, C4B, C2, C1Q, DNS2, and DNSAI3, like that. For instance, chill-brain are also associated with RNase 2A, 2B, 2C, and also intestinal lung disease is associated with STING. Thus, if we see the monogenic lupus and also its association with clinical features, we may really understand the SLE. as I mentioned, SLE is polygenic in adult. However, in kids, monogenic groups may clarify the pathogenesis of SLE and also which lead to the new treatment strategies. So this is summary. Discovery of novel or rare disease-causing gene variants in patients early onset SLE phenotype will have a significant contribution to the unveiling of molecular pathways involving the disease pathogenesis, which should lead to the new treatment strategies. Thank you very much for your attention.
Thank you. We will take up the question at the end. Please, take your seat.
That we also had a very interesting monogenic SLEs with different mutations that have not been reported in literature as of now. Maybe I can discuss with you at the end. Thank you so much.
Okay, please start.
Thank you. Thank you, organizers, and I really commend you all. You should all give yourselves a big round of applause for staying back till 6:45 to hear a boring talk on monogenetic diseases, which you're going to see once every 5 years. So thanks for staying back for the science. My disclosure, actually, I like the second one that I treated. This is, why is this not shifting? This is shifting here. Okay, yeah. So I had a chance to be a rheumatologist to the Indian cricket team 2 days before they lost very badly at the semi-final in Adelaide. And don't blame me for it. I didn't give them any steroids or antihistamines. So it looks like an oxymoronic title, isn't it? Immunodeficiency and autoimmunity existing together. But as you've seen nicely, and the conclusion slide of Dr. Tanaka could have very well have been the first slide of my talk, which is that these diseases give you a unique insight. They give you that unique window from which you could see possibly how intricate are the relationships between different aspects of the immune system. And there is never anything called just hypoimmune or hyperimmune. Most of these are immune dysregulations, and hence you can see both of these coming together. I guess the remit of my talk is to give you how to manage rheumatic manifestations in IEI. But I think I'm going to take a bit of a speaker's discretion there and change, because for that a patient should start with having an IEI, which you are never going to see as a rheumatologist. But I'll still run through the slides quickly to just tell you what it means. So the first thing is, obviously, the nomenclature has changed from primary immunodeficiencies to inborn errors of immunity. The reason being, all these are not just immunodeficiency. And that's why the PID gave way to IEI, because we see that the spectrum has really expanded. And that is because these are the experiments of nature. And these monogenetic diseases, they are like human models, right? They are human knockout models. And you can imagine you are never going to get a cleaner phenotype than studying those in terms of trying to explain either a cellular, a molecular, or a genetic pathway to be able to gain useful insights, which will then translate to treatment. Like PKC delta deficiency that was shown, you are treating an infection with sirolimus. Imagine, who could have thought that you are going to treat an infection with an immune modulatory agent? But now, because we know the modulation as to what causes that T-cell exhaustion, you actually use an immunomodulatory treatment to treat an immunodeficient condition, which is a persistent chronic viral infection. So that's how this has totally transformational potential in terms of the way we are going to look at immune system and these diseases. And as you can see, it's totally exploded, right? Human genome sequencing comes in 2003, and it almost, the genes are doubling every year in terms of the new diseases that are being added to these inborn errors of immunity. And you can see that in last just 3 years, it's gone from 250 to 300, because whole exome sequencing is the norm. The cost of doing a Sanger sequencing is only half of what we would do with whole exome sequencing. So you might as well do whole exome sequencing and have that data which you can almost always re-question years later when you find newer and newer genes being developed. And with AI just round the corner with these technologies, you can imagine that most of these undiagnosed patients will have an answer in 5 years' time. This is the most exciting time that to be in clinical immunology. So this is just hot off the press. This was published 3 years ago by Stu Tangi, who is actually a collaborator when we work on immunodeficiency from Sydney. And as you can see, 485 inborn errors of immunity have been described already. I'm not going to go into details of that, but what I want to do is that immunodeficiencies is just a part of it, right? Only these ones are immunodeficiency, the first 3 ones. But as you can see, the expanded spectrum of it, causing bone marrow failures, the autoinflammatory syndromes, and the intrinsic innate immune disorders that we heard, they can actually cause an adaptive immune disease. Like lupus was always the prototype adaptive immune disease, having lots of autoantibodies. And the problem actually is innate immune system. The problem is type 1 interferon. So these things are going to come together with this explosion of information that we are going to get with coming together of genetics and the bioinformatics, being able to probe possibly every gene that is there in these pathways. And that's what these things are going to do, right? So now they have published very nice correlations as to, and I'm not going to go into details here in the interest of time, but as you can see, most of these IEIs that I showed, and I'm not going to walk through each of them in interest of time in 15 minutes and this time of the day, but can actually present with multi-system disease. So one thing is, as an adult immunologist, and I was asked to talk about how to manage adult patients, because we almost always talk monogenetic diseases being in the pediatric arena, but now we know with certain somatic mutations, and that's what I'll touch on, that they can present in adulthood, right? So they can be associated with lots of different vasculitis. So if you see any multi-system disorders, that's when you start thinking, and that's what my last part of talk is going to be. Not about how to manage these diseases if they have IEIs. It is more going to be for a rheumatologist. What's going to be more exciting is that when to think of an IEI in a patient sitting across you when he presents with rheumatic manifestations. Yeah, makes sense? So, and the most common in terms of adult that you're going to see, adult patients, is going to be with common variable immunodeficiencies, right? But there are few publications which have shown that the extent of involvement. And as you can see, you really start thinking about it when you have either cytopenias or gastroenterological involvement in addition to your arthritis. So none of these patients are going to present traditionally like undifferentiated arthritis. No, they would be more likely, because there is a global immune dysregulation, they most likely are going to present with multi-system illnesses with cytopenias and gastroenterology disturbances. That should raise a flag. Don't attribute it to the drug that you used to treat that condition. Start thinking that if there is a pattern, this actually might be a primary immunodeficiency. And then obviously, if you do a meta-analysis, you can almost find every organ being involved, as you would expect. But those are the first 4 ones that I would really be focusing upon in terms of raising the alarm bells as to how extensively you need to investigate. And as I said, it was initially thought that only CVID would be the ones that will be most prevalent. But as you can see, other T-cell deficiencies, innate immune deficiencies, they are equally prevalent in this group, which can present with rheumatic manifestations. So that is common. And not just the importance is in detection and making a good diagnosis and presenting it in conferences. It actually means something for the patient, because these are the ones who have worse prognosis, and these are the patients who are actually receiving immune replacement therapy, by the way. So they have been correctly diagnosed at appropriate time and they are receiving correct. And despite that, the prognosis actually is worse. So they have a shorter outcomes, as you can see here. So that's the reason why it is more important. And as you can see, the relative risk, 120. So if you have an immunodeficiency, you are more likely to have cytopenia 120 times the magnitude as to any other person walking, right? So which means that these things should be in our mind, and you should start raising an alarm bell. And not in distant future, we are going to have whole exome sequencing facilities here in India, right? It's going to happen the China way, whereby we are going to have 5,000 rupees exome report as well. So these are the things that should actually start raising the bells. I wanted to speak a bit about common variable immunodeficiency, because that's the one that you're most commonly going to see in terms of adults, if we are not talking to children here. And I wouldn't go through details in interest of time, but what I want to tell you is that most of the diagnostic criteria for CVID, look at that. The increased susceptibility of infection is just a part of a diagnostic criteria. The rest 3 of the clinical are autoimmune manifestations, granulomatous disease, unexplained lymphoproliferation. These are all going to fall into our arena, right? We are going to get reference because of that. So So it is up to us, as I said, to think about these diseases, especially in those unusual ones. And I'll give you my take on it. There is no published recommendation, but I'll give you my take upon it as to when you should start thinking about evaluating the immune system in a patient presenting in your clinic. I'll give you a couple of examples of how this will really help in terms of making a therapeutic challenge as well. So as you can see, there are at least two of the CVID conditions relating to CTLA4 and LRBA. I don't need to talk more about CTLA4, I guess. It is an immune checkpoint. I'm sure you know about the first and the second signal hypothesis. This is part of the second signal and cutting off of the immune hyperstimulation. So if you have problems, you can imagine that the first pathway just continues to fire and amplify. And it goes into a self-amplifying loop and continues to proliferate. So no-brainer, that would cause autoimmunity, right? And the same thing LRBA does, although the exact function is not known, but it is thought that it is responsible for the intracytoplasmic processing of the CTLA4 molecule in terms of its degradation. So if LRBA is not there, the CTLA4 is taken more into lysosomes and degraded. So you can imagine that it is same like saying that there is no CTLA4. So these two are very related ones. And once these were discovered, I'm not going to go into details, you can imagine we have, there is something that is splitting. But as you can imagine, we have a CTLA4 immunoglobulin, right? We can do replacement. This is like replacing a deficiency that you have. So you just replace it. So abatacept, as we all know, and as you can see beautifully there in the circles, once the abatacept was started, the clinical, this is of autoimmune cytopenia, it rose quickly after just 4 injections. And the patient has been well thereof. So that tells us about CTLA4. And that tells us about, if you have arthritis, autoimmune cytopenia, this could be your first go-to drug. So this will be as close as you can get to precision medicine, right? So that's why the importance of being careful. And this is again one of the patients of LRBA where it shows similar things. So that's the importance of knowing about these autoinflammatory syndromes. Now actually I could have just shown this slide and finished my talk, because that was the directive given to me, which was how to treat. I'm not going to go into detail of each of those features as to what you do if you have gastrointestinal, what you do if you have respiratory, what you do if you have arthritis. Let's use one word, you just manage them as if there was no IEI. Okay? Because the immune dysregulation has happened, and if the clinical phenotype fits in with that particular syndromic involvement, you just treat them. So let's say if you have gastrointestinal involvement, you would go for TNFs, right? You will go for vedolizumab, which are the adhesion molecule inhibitors. Versus, if you had more autoimmune phenomenon, you'll go cytopenias, you'll go for rituximab, like we always do, right? So the syndrome, that part of treatment doesn't matter, and that's why I pay least emphasis on that part, because we all are used to, as rheumatologists, doing, and then you wouldn't do anything different just because the patient was diagnosed with IEI. But as I said, I'm more interested in when you should start thinking about it, and I think I'm going to leave, because all those slides said that the genetics, the study of genetics, has still come back saying that they are complex genetic traits. So it's excellent from what Professor Tanaka showed in terms of, he gave us some insights into type 1 being involved as well as the adaptive immune system. But we still keep talking about complex genetic traits and multiple loci, and we don't know what that means. Which means that if you get these, when you start thinking about immunodeficiency disorders, there will be a certain phenotype that you're going to find, and then that will open the floodgates, right? As we have seen with this publication. Every adult rheumatologist has to read this publication. I'm not going to go into detail in interest of time about how this paper went about, but every student has to read it. Such a fascinating way to discover a disease, which is genetics first approach, and how they went about it. They started with just 3 patients to get into NEJM, right? And then they had the disease phenotype, then they found that all were males, and hence the X chromosome. Then they went to other centers which had, and I'm not doing a journal club on this one here, but I like to do it in my talks because it is just fascinating the way they did it. And this potentially has the potential to just change the way we are going to look at adult diseases. Because this is all adult male patients, right? And this is not a Vexus talk. I would love to give one because I'm very passionate about it. But I would leave it at that, and I would want all of you to read it. And what it has opened up is that somatic mutations, we always keep thinking that, somatic mutations means cancer. And then we had few, like PNH and those kind of diseases where we knew that somatic mutations can have an effect. But this disease has totally thrown at, you have review articles in almost every journal talking about somatic mutations in benign diseases, inflammatory diseases. And it's fascinating how this is going to change. Again, that is not part of my talk, but I think somatic mutations are going to be the answer. As Professor Tanaka said, if we actually had did single gene sequencing studies on your dendritic cells in peripheral blood, maybe that is the only cell that is carrying mutation. Now that won't be picked up in whole exome, or even if it is picked up, the frequency is going to be so low in terms of those complex algorithms that are being applied by those bioinformatic people, that you are never going to, the odds ratio is going to be here. So you're going to take lots of time to be able to reach and assign any significance to that particular odds ratio. It's there, it's lying in front of you, right? So, this is my last slide. So, when should you start thinking about possibly thinking whether we should evaluate with immunodeficiency? Now, immunodeficiency is, I'm not saying you should do whole exome sequencing. You can just do some simple screening, immunoglobulin levels and lymphocyte surface markers, which is your BET and NK subsets to start with. That's all that is required. And these days they are available in all metropolitans, I know that. It's about 2,000 rupees, which is nothing when you're talking about chronic disease situation, where they would be spending almost 10% of their earnings on their health anyway. Right? This has a potential to totally change the way you manage them. So if you have a young patient, younger age, if you have multi-organ involvement, as I said, most importantly, if you have a seronegative patient. In modern day, seronegative lupus does not exist. There is nothing called seronegative scleroderma. There is nothing called seronegative Sjogren's. As I keep saying, if you have seronegative, that should set an alarm bells that this is possibly something else. And that's where you need to take more detailed history taking in terms of trying to find that subtle clinical traits to start ordering for these tests. If they have recurrent infections, now we almost always tend to think that infection is what we have given to the patient, right? We start immunosuppressive medications, they come in and we say methotrexate, infection. No. If you get anything more than 2 infections and 2 pneumonias, that methotrexate never does that. It doesn't cause your immune suppression. It's an anti-inflammatory, it's not immunosuppressive. So if you get 2 infections, you should order an immunoglobulin level as a minimum in your patient with rheumatic disease. Don't just attribute it to the treatment that you're giving. It is possible they might have hypogamma, as was discussed in one of the sessions today, right? Or in the CPC. Someone I think got up and asked if this could be CVID. That was a fantastic question. That's what you need to ask yourself. Family history, definitely. We don't take family history in as detail as possible. We do take it for the immediate relatives, but that's not what you want. You want any undiagnosed deaths in the family. घर में कोई मर गया था क्या जिसका पता नहीं चला कि क्यों मरा था? हार्ट की डिजीज से नहीं. We ask कि हार्ट की डिजीज से कोई किसी के अर्ली एज डेथ हुई है क्या? अर्ली एज कैंसर हुए क्या? We don't ask unexplained young deaths. That's the question that you need to ask if you want to find out whether you should be investigating further. Not fitting into a syndromic diagnosis, as I said, rheumatoid arthritis mein thrombocytopenia is not common. Don't go for labeling RA and then ITP. No. Put them together. Could this be CTLA4 deficiency? Right? So don't just keep adding on the individual syndromic diagnosis as no. RA mein, if you called it RA, thrombocytopenia is not common. Neutropenia is. Thrombocytopenia is not. You know what I mean? That's when the alarm bells should start ringing. If they don't fit into your classical syndromic pattern. And lastly, as I said, Vexus is here to stay. And I have not put a Vexus slide because although it's close to my heart, as I said, you can see the clinical syndrome is exploding. What started out with greater than 60-year-old male patient presenting with recurrent. Now we are saying the age is coming down younger. And you can imagine why can't somatic mutation occur in young? It is like saying you can never get cancer at the age of 20, right? So if you have any cartilage inflammation, any unexplained cytopenias with high MCV, or the skin biopsy is neutrophilic dermatosis, not lymphocytic or macrophage-mediated inflammation, you think about Vexus. Thank you.
Thank you, sir. It is now very freely available as low as 12,000 rupees. And we have started doing it very, very routinely, and it's available. The rest of the investigations, like sir was saying, it's available in all the government hospitals free of cost. And sir, I'd like to share, we had one patient who had basically severe sepsis semiology. We couldn't understand why the kid is not responding to the antibiotics. The age was 8-month-old baby who came with a lymph node abscess, and we got pus from one of the nodes, but he got sicker and sicker despite colistin, linezolid, we added caspofungin also, I couldn't understand, but the CRPs were sky high. COVID serologies were negative because everybody is thinking of MIS-C. So what happened was I thought of a PID or a IEI, I should not say PID because I keep telling my PGs that there's nothing like PID, it's IEI. So sir, when we investigated the child, we managed with immunomodulation, we gave IVIG 2 doses. We were almost about to give infliximab, but he responded to the corticosteroids, and when we did the whole exome, he had a heterozygous mutation of familial Mediterranean fever gene, a pyrin mutation. So we don't actually know whether all that we are labeling as sepsis, which comes out to be culture negative, we should definitely do a whole exome, try and find out whether there's some heterozygous mutation. Similarly, we had another child with a heterozygous mutation of DIRA with the autosomal dominant mutation of S5K, which is immunodeficiency with autoinflammation. So, this field is so interesting. It's so interesting. In fact, for sir, I had one patient with SLE. He was a 14-year-old boy with fleeting ANAs. एक ANA positive आ गया, 6 महीने बाद negative हो गया, फिर positive हो गया. Severe mass, going ferritins into 20,000, 30,000. When we investigated, he was heterozygous for C3 defect. He was also having Klinefelter's mutation. So we don't know how these mutations are working, how this epigenetic phenomena, we don't really know what's happening. So sir, I'm so thankful for both the sir's talks. Can we take a few questions? Supreet, do you have any questions? Anybody?
Yes, sir. I have a question, sir. We generally see many patients, young boy, like 3 years, 4 years, with ANA positivity, with arthritis, with developmental delay, and have rash. We have a patient like that, arthritis predominant. And when we investigated, whole exome showed mutation in DNS2. So how to manage these cases? Because they will not respond to MMF or hydroxychloroquine we gave, but still the arthritis is persisting. And any role of JAK inhibitors?
We had a patient with DNA, so he had a patient.
This is for your.
This is for you, sir. He said that he has a patient with DNA defect and he has arthritis. The patient is not responding to the classical.
It's very difficult to treat this patient, but usually we have to do the immunosuppressive treatment as shown in the adult onset disease.
No, he is telling what he will give, microfluoride or other drugs. No, sir, you sir, answer.
How do you manage arthritis in this patient with DNA?
So as you mentioned, same as management of arthritis or for the skin eruption or others are same as done with adult onset SLE. Usually.
So you're saying that the management does not change with the presence of mutation, you probably have to treat it the same way you would treat an adult onset.
Yeah, I also got one patient of monogenic SLE Medical College, some dwarf monogenic SLE about the neurological problem.
Yes, they
So,
generally have
monogenic
more
is-
CNS involvement. Monogenic SLE has more CNS involvement.
CNS involvement, and this is the most striking thing. So a patient came, especially the male patient, with SLE, with CNS involvement.
We should do a whole
think of this monogenic SLE. This is the message.
The monogenic variation of interferon may induce hyperactivation of B cells or T cells. So that is the same as adult onset severe SLE. So that's why you need to treat the patient or manage the patient as adult onset severe SLE with glucocorticoid immunosuppressant and maybe sometimes rituximab or other biologics.
Thank you everybody. This is the new thoughts. So we'll have to learn more, we'll have to see more patients, we'll think about more patients. Thank you sir, coming from a long distance and enlightening us.
Thank you very much. Sir, do you see C3 defects also?